Our next speaker is Mr. Koenig, who will be speaking to us on platelet-rich plasma and platelet gel. Mr. Koenig is the founder and president of Comprehensive Blood Management for the past 20 years. His company specializes in blood management intraoperatively. Gary is from Wilson, North Carolina, and graduated from the Medical University of South Carolina in 1994 with a degree as a cardiovascular perfusionist after serving 5 years active duty in the United States Navy. He is a certified and licensed clinical perfusionist, a perioperative blood management specialist, as well as a certified autologous blood therapist. Gary also serves as an assessor for the Association for the Advancement of Blood and Biotherapies for the standards for perioperative autologous blood collection and administration. Gary has a tremendous amount of experience and passion for blood management and regenerative medicine, and he enjoys sharing his knowledge and experiences with others. He is married with 2 daughters, and he is an avid outdoorsman. So we're here today to learn from his knowledge, and it's a good thing that he enjoys sharing it. So please, let's welcome Mr. Koenig as he speaks to us about platelet-rich plasma and platelet gel.
Thank you so much for your introduction. I've been doing perfusion and working with blood management for the past 29 years. Another area which we're heavily involved in is another type of autologous therapy called platelet-rich plasma or platelet gel. And today, I would like to share with you some of our experiences and the different types of surgery where we can use this autologous product. So we also know that the platelet, all textbooks and references refer to platelets that state the function is to form the platelet plug. While that's true, there's much more to platelets than this. So they're keystone to haemostasis, major contributors to healing, both of tissue and bone. What is platelet-rich plasma and platelet gel? So both these have to do with the autologous product of taking whole blood, and they're similar in the only difference really is the platelet gel, you have additives added so it stays in place. So when you spray it on topically, it stays on the tissue or bone where you want it to be. So platelet-rich plasma is blood plasma that has been enriched with platelets. As a concentrated source of autologous platelets and white blood cells, PRP contains several different growth factors and cytokines that stimulate the healing and soft bone. Here are some of the main growth factors that will be listed in any articles you read on PRP. There's platelet-derived growth factor, which helps stimulate cell replication. A very important one is VEG or VEGF, vascular endothelial growth factor for angiogenesis, for neovascularization. So actually you can increase the blood supply to a certain area of the body by using this product with this growth factor. There's transforming growth factor beta, which helps with the bone and cartilage formation. There's epidermal growth factor, which stimulates primitive cells and enhances other types of growth factors. Insulin growth factor mediates growth and repair of skeletal muscle. And fibroblast growth factor, which stimulates myoblast and angiogenesis also. So platelet-rich plasma appears to be effective for preventing the growth of Pseudomonas and staph. And they have many bactericidal effects. The infection-fighting peptides of platelets are increased in direct proportion to the concentration of the platelets within platelet gel. White blood cells. So as the density of white blood cells is similar to platelets, white blood cells are concentrated along with platelets, and it's also called the Buffy coat. The combination of white blood cells and platelet peptides further enhances infection-fighting capabilities of platelet gel. So a study at the Department of Orthopedics at West Virginia University looked at a new approach to prevent infections. They found that PRP had strong antimicrobial properties against bacteria like methicillin synthesis and methicillin resistant staph and strep. So the conclusion of this particular study was the use of PRP has the potential to prevent infections and reduce the need for costly postoperative treatment of implant-associated infections. Platelet-rich plasma inside a sternotomy wound reduces the incidence of sternal wound infections. This was a Journal of International Wounds and Cardiac Surgery Unit. They looked at, in group A, they had a control group that did a sternal closure without the application of PRP. And in group B, they received PRP inside the sternotomy wound before closure, and deep sternal wound infections were significantly higher in group A without PRP, 1.5% versus 0.2%. So the conclusion of the study was the use of PRP can significantly reduce the occurrence of sternal wound infections and superficial sternal wound infections in cardiac surgery. And I'm not sure if you're familiar or not, but one sternal wound infection in the United States can cost $50,000 or more. And a patient can spend 2 or 3 months in the CVRU and post-op. So what is the source of this platelet gel? Again, it's from our own body. It's an autologous product. The process is performed point of care with a tabletop centrifuge. So the whole blood is anticoagulated and is collected in a syringe or a blood collection bag. The type of anticoagulant can be citrate, ACDA, sodium citrate, CPD. The process, depending on which machine we use and what we're trying to do, what type of PRP we would like to make, whether it's leukocyte rich or leukocyte poor, can take anywhere from 1 to 16 minutes, depending on the machine and procedure. Where can this platelet gel be used? So it can be used anywhere that bone or tissue has been injured, cut, or burned. There are no documented limitations to the use of platelet gel. Platelet gel, to a large degree, it can also help prevent the formation of adhesions and scar formation. As far as an injecting therapy, an alternative to hyaluronic acid and steroids, it can repair tendons and cartilage injuries. So the collection and processing, a whole blood collection, a consent from the physician is required for PRP. Blood is drawn at the same time as the IV placement to limit multiple patient sticks, and it is collected into a bag or a syringe, and anticoagulant is utilized. So blood, typically 1 gram of blood 1 ml of blood equals 1 gram. Blood is drawn from a previously unused access site according to AABB peri-op standards. The top slide shows blood being drawn off in a blood bag for PRP, which is rarely used because you can use, all the cell saver machines have an option to make PRP, and it requires more blood to do so. Today, small volumes of blood are utilized in typical 60 ml syringes to process and make PRP or platelet gel. So this is an IV antecubital stick with PRP extension set. We'd like to use the antecubital vein. It's larger. The angiocath is an 18 gauge. You would like to use an 18 gauge or larger angiocath, and because when you pull, you do not want to pre-activate platelets due to excessive negative pressure. Here's PRP collected from an autotransfusion machine by an autologous blood therapist. It's the machine, the blood is run through the machine, typically 300 to 500 mLs. The PRP is drawn off into the syringe for the patient, and the blood can be given back to the patient after the procedure of processing. So what about the blood draw volume? How much blood do we need? So it's really going to depend on what we're doing. So in certain cases, if we're doing injection therapy for musculoskeletal injuries, if we have lateral epicondylitis, an Achilles tendon tear, if we're doing an injection of the knee for osteoarthritis, anywhere from typically 10 to 60 mLs for those cases, but we can draw up to 180 mLs for some of the tabletop machines, and 300 to 500 mLs of blood if you're using the autotransfusion machine, which is these days is very rare. And the ratio of platelet-rich plasma in a whole blood is about 1 ml per 10 mLs of whole blood, or 10%. So that means that if we do a 60 ml whole blood draw, 10% is 6 mLs. So that 6 mLs of PRP platelet gel will have a concentration typically of 400% platelets and growth factors above the native baseline levels. Blood processing. So the blood is centrifuge point of care. Blood is taken off when the patient comes to the pre-op. When the IV is being put in, the equipment is FDA cleared. Equipment selection, again, depends on the blood draw and the final product required. Whenever we centrifuge blood, obviously it goes into plasma is the lightest part, the buffy coat, which has your leukocytes, your white blood cells and platelets, and your erythrocytes or red blood cells. So centrifugation is based on weight. As you spin it around at high speeds, 3,000-4,000 RPMs per minute, it's going to separate out like this. So the PRP is typically, we're pulling off the buffy coat where the leukocytes and platelets reside, and sometimes some of the plasma too. And this will vary depending on if we want the white blood cells or do not want white blood cells. So our target platelet count. So the target platelet count is measured. We typically, if we're dealing with aesthetics or soft tissue, wound healing, we want at least 3 times the concentration of platelets. So if a patient has a 200,000 ml platelet baseline count, we want at least a 600,000, about 3 times that amount for soft tissue. Now, if we're dealing with bone, where we're trying to get bone to fuse together for arthrodesis, or we want cartilage to regenerate and to regrow, we want at least a 5 times concentration of platelet concentrate. So this is just showing a picture of an applicator on the OR table. As you see, you have a red product. That would be the PRP, platelet-rich plasma. The syringe on the right, the clear syringe, is calcified thrombin. That serves as an activator. When syringes are loaded, they look like this. On the left side, you see platelet-rich plasma with calcified thrombin, the clear syringe. And on the right-hand side, you have platelet-poor plasma. So whenever we take whole blood off, we actually get 2 things to use for the patient if we would like. One, we have PRP. So platelet-rich plasma has a high concentration of platelets. It can have a high concentration of white blood cells for an antimicrobial effect. You also many studies have shown a reduction of pain after surgery. And also, both of these products provide hemostasis. They both can be used as a hemostatic agent. The product on the right is what we call is PPP, or platelet poor plasma. The concentration of platelets in that syringe is typically around 5,000 per ml, but you have a higher concentration of your plasma proteins and fibrinogen in platelet poor plasma, and that's only used for mainly just hemostasis. So our activators for PRP and PPP, you have bovine thrombin. The FDA does have a black box warning on bovine thrombin of potentially developing antibodies against factor V. And upon re-exposure of bovine thrombin, patients could bleed or have coagulopathies. The other option would be the Recothrom, is a recombinant type of thrombin. Then we have Jehovah's Witness patients. We use Recothrom. We don't want any animal or human products, so we use Recothrom for those patients. There's also autologous thrombin. We have trialed there's 2 or 3 products out there that you can make autologous thrombin. The only problem with that is what we have seen is the clotting the platelets do not gel as quickly. So if you spray it on, it tends to run off, or it takes longer to activate. The calcium actually binds the citrate, the anticoagulant. So when it's sprayed on, the calcium reverses the anticoagulation. And once the thrombin crisscrosses with a high concentration of platelets, that's when you have the release of the alpha-granules of your growth factors and cytokines and anti-inflammatory mediators. So how is PRP used in surgery? So here's PRP sprayed underneath a flap during a surgical facelift. Other products, hemostatic agents such as your TISSEAL, FlowSeal, CoSeal, when you use those products in procedures like these, it's not pliable. The tissue is no longer pliable, meaning that it doesn't really move very easily. When you use PRP, such as in this picture, it actually provides hemostasis and healing, and it also is, you can still move it around fairly easily. Now, here's a procedure of a surgical facelift, again, upon surgical skin closures. If you put PRP on skin closures, you can have less scar formation. Long-term survival of fat grafts. Some surgeons add PRP to their fat graft transfers. So you have a fat graft as an upper cheek implant graft here. It increases the survival of the fat if you put PRP with it. There's a study on breast reconstruction and surgical innovations with autologous fat mixed with PRP. They had 50 patients between the ages of 19 and 60. They had breast soft tissue defects. They were treated with fat grafting and PRP mixed together. The control group were 50 patients with breast soft tissue defects were treated only with fat graft injection, and the other 50 were used with the PRP and fat mixed together. So the patients treated with PRP and autologous fat graft showed a 69% maintenance of contour and three-dimensional volume after 1 year, whereas patients of the control group without PRP only showed a 39% maintenance. So the conclusion was PRP mixed with fat grafting leads to improvement in maintaining breast volume in patients affected by breast soft tissue defects. Also, for abdominal liposuction, after liposuction is done, you can actually use PRP to help heal, and it also decreases the formation of seromas and hematomas. We have carotid endarterectomies, so you can use again, the PRP is for healing, the PPP is for sealing. So you would want to apply platelet-rich plasma on the tissue to begin with to promote healing and decrease the risk of infection, since you do have a high concentration of white blood cells. The PPP is sprayed on next, and that is just a topical sealant, like a hemostatic agent, but is an autologous in nature. Here's PRP hemostasis achieved during body sculpturing following gastric bypass after weight loss. We also do robotic procedures. There are long 40-centimeter tips we can use for robotic gastric bypass, gastric sleeves. We use those also for robotic hysterectomies. You can actually put the PRP directly on the incision side or where the operation was performed to reduce scar tissue adhesions, reduce adhesions, to accelerate wound healing. And then you also can use the PPP or platelet-poor plasma as a hemostatic agent topically. PRP to free grafts works very well. Split thickness skin grafts, burn patients, you can use this. It causes the graft to adhere to the tissue more readily, and it's an autologous product. Total shoulder replacements, we can inject the PRP upon closure after the washout, after irrigation has been done. We would apply the PRP onto shoulder replacements to accelerate healing. Platelet gel applied to diabetic heel wound. Last year, the United States Medicare approved PRP for chronic diabetic wounds, 30 days or more, up to 20 applications, 1 application per week. So that is some very exciting news for chronic diabetics and wound care in the United States. PRP can be used for enhanced healing and the prevention of seroma formation. As you see, you have a lipoma extraction, and when you put PRP down in there, it actually can help seal and promote accelerated healing. PRP also can be applied for gallbladder and polyps removing. Both of these products, PRP and the PPP, platelet-poor plasma, provide hemostasis. The PRP has the advantages of a high concentration, again, of platelets and growth factors and cytokines to accelerate healing. Endoscopic knee repair, we actually do this in some of the ambulatory surgery centers, same-day procedures, where we do knee repair, shoulder scopes, Again, patients seem to heal quicker. Their range of motion is, they respond better with range of motion, and having very, very good results for endoscopic repairs. PRP is applied underside to a total knee replacement. We applied the PRP to any exposed bone or soft tissue. Once the first layer is closed on the subcutaneous layer, we apply the PPP platelet poor plasma, the yellow product for hemostatic for any oozing. There's PRP to an ankle reconstruction done. For ankle fusion, we can mix it with graft materials such as cancellous chips, demineralized bone matrices to cause the graft material to hold better and promote fusions. We also make bone logs sometimes for spinal fusions. As you can see, cancellous chips are in the center. We have PRP on the right syringe and the calcified thrombin on the left syringe. Those syringes are pushed down. They fill up the cancellous chip syringe, saturated. Basically, that's a bone log. We have cancellous chips on the left. We make a bone log. Those actually can be placed in the gutters for spinal fusions, and also can be placed in cages. So sometimes surgeons will pack the cages with allograft material or autograft material, and we can add PRP to promote healing and promote fusions. There are the bone logs for spinal fusions. That's a spinal reconstruction case with PRP impregnated within the bone grafts. PRP has been used for bone fusions for a good while. In the last few years, we've actually started doing bone marrow aspirate draws from the iliac crest, either the posterior or anterior, and we actually concentrate the mesenchymal stem cells to promote and to mix with the graft material like we do with the PRP. There's a lot of data out there. The cost is much less than a lot of the allo stem cell products that are used today and other types of products used for fusions. When a saphenous vein is harvested, PPP can be provided for hemostasis. The internal mammary artery is harvested off the intercostals, and as that's taken down, there's a lot of oozing and bleeding. You can apply the platelet poor plasma for hemostasis. Again, for sternal hemostasis and closure, that would be platelet-rich plasma applied to the sternum, and then they will be closed. Again, we're trying to prevent sternal wound infections, which are very costly and time-consuming for the patient. One of the first places that PRP was ever used in the mid to late 80s was in dentistry. And this is PRP applied to a third molar extraction. This way you can basically eliminate any dry sockets and you have hardly any pain after surgery. And there's a top coat of the platelet poor plasma just as a sealant sprayed on the top. And this is PRP with bone reconstruction of a draw. As you can see, there are cancellous chips there, and it's been mixed with PRP for diffusion. So the clinical relevance of treating chronic wounds with a nearly enhanced concentration of platelet-rich plasma. So this was in the advances of skin and wound care. The study they used for chronic non-healing wounds, 39 centers contributed to this registry. They had 285 chronic wounds. The wounds etiologies included diabetic, pressure, venous ulcers, disease, surgical or traumatic wounds. The results, a positive response occurred in 96.5% of wounds within 2.2 weeks with 2.8 treatments. In 86% of wounds, there was almost 50% reduction occurred, and 90% of wounds had a 63% volume reduction. So in conclusion, wounds, chronic wounds utilizing PRP gel can restart the healing process. Rapid treatment response was observed in 275 to 285 wounds, and the magnitude was consistently high. This is not a very clear picture, but this is a patient we did a few years ago. This gentleman came in. He was a 57-year-old diabetic, heel wound. He was in the prone position. They wanted to go in and amputate this patient's foot. But before that, we suggested, why don't we just try the platelet-rich plasma? You know, we have nothing to lose. It's an autologous product. we can try and see what happens. So we went into the OR and we did a very aggressive debridement. That is the PRP sprayed on topically. The wound is wrapped up with a non-adhesive dressing. The patient comes back a week to 2 weeks later, and we look at the wound and determine if we're going to do another application. So this is 2 weeks post PRP application. As you can see, you have quite very nicely pink tissue granulation formed. And we did another application at that time. This is after the third application, this same wound, 8 weeks post after our third application. And that's 8 weeks after our third application. Again, another picture, but you can see this patient healed all the way and were able to save his foot. This patient was done about 4 months ago. It was a 90-year-old diabetic chronic wound. They amputated this patient 2 of his toes. He had gone through 30 days of HBO, hyperbaric oxygenation. As you can see, you have the white areas that's either like bone or cartilage showing there. So we went in and we did an application of PRP. And after, this is not a very clear picture, but as you can see, there's new tissue granulation. This is about 1 week after our first application, and you can see a reduction in the size between that picture and that picture of the wound. So we did another application. We spray PRP on. As you see, it's a very glossy thing. So when you spray PRP on, when it's mixed with the activator, within 15 seconds, it actually stays on the wound like that. That patient's foot is standing straight up, and we sprayed PRP on there, wrapped it up with, again, a non-adhesive dressing, sent him home, came back another week. And these are 5 weeks out. And then 7 weeks out, he had complete healing of his foot. This is a 55-year-old diabetic cancer patient we did 4 months ago. When I looked at this wound, I really thought that this was going to be very challenging, and it was. This patient, they stopped his chemotherapy to try to heal his wound, and we did 1 application, and he came back, and we have brand new tissue. This is 2 weeks post-PRP application. You can see new tissue granulation forming where we had none there. We did another application, and this gentleman, this patient, went on for complete healing, and he was able to restart his chemotherapy. So PRP therapy risk and side effects. There's always risk, of PRP is bleeding, tissue damage, infection, and nerve injuries. And this mainly pertains to our injectable therapy with PRP as far as drawing blood off. Contraindications, anticoagulants, such as warfarin, heparin, critical thrombocytopenia, a very low platelet count. That's not always a absolute contraindication. It's more of a relative contraindication. We can do things to basically increase the platelet. Even if a patient has a very low platelet count, we're able to concentrate, take a little bit more blood off, and concentrate those platelets to the level that we won't need them at or want them at. Hemodynamic instability, obviously, if a patient's unstable. Infections, acute and chronic, would be another contraindication. So expected outcomes when we use platelet-rich plasma. We have now closures without placements of drains, virtually no swelling or bruising. Passive bleeding is eliminated when we use platelet-poor plasma for hemostasis. So we eliminate homologous blood products. Pain is reduced after surgery. Range of motion is better postoperatively. We have an increased risk of infection because we have a high concentration of white blood cells. Potentially, we have earlier discharge, and we have enhanced healing and recovery. So I would like to challenge you, too, to think that if we're able to heal wounds topically, like we're able to do now with chronic wounds, that patients go up to the wound care center every week for sometimes up to a year. We've healed wounds of that nature. So if we're able to spray and use PRP onto topical wounds, onto chronic wounds during other types of surgery, on some of the pictures I've shown and shared with you today, that is exactly what is happening inside the body during surgery. So we're having a high concentration of growth factors, of cytokines, of anti-inflammatory mediators, so we can actually increase or accelerate wound healing, but we also can have hemostasis. So we have been using PRP for 21 years. We've done over 70,000 PRP cases. And in the United States, at least, it's being used more than it's ever been used before. The cost, excuse me, the cost of a PRP kit has substantially decreased. Actually, I trialed a new system that came out 2 weeks ago, and their cost for disposable to be able to make PRP is just $75. So it is very reasonable as an autologous product. And I think it's something that if you've never been exposed to this or you've heard a little bit about it, you should investigate it more because it really can help your patients out. Thank you.